So good morning, everybody. Thank you all for being here. For those who I don't know, I'm Sandro Galea. I have the privilege of serving as Dean of the School of Public Health here at Boston University. For those of you visiting us, welcome to the School of Public Health. So but before I start and frame today's symposium, I just want to start with a couple of acknowledgements. First of all, most importantly, behind events like this, there are always thousands of people who make things happen. I want to formally thank the team behind this, particularly Meg Keating, who keeps these kind of events together. Thank you, Meg. I don't know where she is, but I'm sure she's around making something happen. Secondly, I want to acknowledge that this symposium is in part sponsored by the Joe Lopez Lectureship on Racial Disparities in Health. That's sponsored by Dr. Russ Lopez, who's right here, and Mr. Andrew Sherman, who, Andrew's not here, but we'll thank him in absentia. On the inside of your program, it actually says a little bit about Joe Lopez and his dedication. So thank you, Russ and Andrew, for sponsoring this. This symposium is part of a series of quarterly symposia that we're doing here at the School of Public Health. And the intention behind these symposia is we bring together really experts from all over the world to discuss and tackle issues that are close to the school's heart and part of the school's, close to the school's mission. And really there is no topic that is really closer to the school's heart than this notion of place and health. The school has been through, over the past couple of years, a strategic planning process where we've identified several areas that are cross-cutting thematic research areas of interest for us as a school. And the idea of cities and places and how they affect your health is really at the top of the list of things that we care about. So today's symposium is, I think fair to say, built on three premises. So the first premise is as follows, is that where you live matters. It shapes the food you eat, the water you drink, the air you breathe, how you think, how you feel, and how you behave. And in many respects, you've all self-selected. You've come into the room because you probably think that. It's unusual that we attract people who come in and say, because actually I disagree completely with the premise. We probably should do more of that, but we don't do enough of that. So there's a premise that where you live matters. That's the first premise. The second premise is that we've had 3 decades of scholarship galloping forward in this area, in part informed by methodological changes, in part informed by theoretical advances, in part informed by the engagement of bodies like the World Health Organization that have really started coming to bear on this issue of how does where you live affect you, how does where you live affect your health, and how can we understand that. And the third premise is that having done this for 3 decades, it's really time to, in some respects, move beyond understanding, to move to perhaps a more interesting phase, to say, okay, well, what can we do about it? If we understand that where you live affects your health, then what can we do about it? How can we modify, how can we improve where we live to the end of improving the health of populations? I frequently note in my talks that what really matters to improve the health of populations are the ubiquitous forces. And where you live is ubiquitous because we share where we live. And if we really want to shift the health of populations, we need to shift the ubiquitous forces that shape where we live. And this meeting today, this symposium around the physical environment and how that affects our health, very much tackles that. And as you'll see in the flow of the day is structured to start off with really an inquiry around the scholarship and then moving into what we know so that we can figure out what we can do about it. And our intention behind the symposium, as it is with all these quarterly symposia, is to bring us all up to speed on the state of the science towards a looking ahead. What we'd like to do is end the symposium smarter for having started it, smarter for having spent the day together, and understanding what are the open questions and what are directions that we should take in order to identify how we can figure out how where we live shapes our health and what we can do about it. So having said that, now I want to introduce the person who's actually the brains behind this, and that's Professor John Levy. So Professor Levy is Professor and Associate Chair of Environmental Health here at the School of Public Health. There's a long bio of John in the program, so I will not repeat all that. John is also the co-principal investigator at the Center for Research on Environmental and Social Stressors in Housing Across the Life course, CRESH, which involves interdisciplinary research at the intersection of environmental epidemiology, health disparities modeling, and community-engaged research, which in many respects has been the animating concept behind what brought about the symposium. When initially we started thinking about symposia to launch at the school about 1.5 years ago, it was very clear that not only was this the right topic, but that we're very fortunate that Professor Levy in our midst is a world leader and the real thinker in this area. So it's been a delight working with him on this, and I'm very much looking forward to the day. John.
All right, well, thank you, Sandro, and good morning, everyone. Thanks for joining us here today. I'll be very brief. We want to get to our amazing panel of speakers. I think Sandro really set the scene for what we're here to talk about today, which is really what I think is one of the core questions of public health and health in general. How does where you live affect your health? And the sequence of the day really focuses on thinking about the built environment, our neighborhoods surrounding us, then thinking about the physical homes that we live in. And as Sandro mentioned, the final panel really engaged on solutions, how researchers, residents, policymakers can all work together to affect change. I think trying to tackle this question is complicated because there are so many factors, so many issues. When you frame this question, you could be thinking about burning fossil fuels in homes in India. You could be thinking about flame retardants in furniture in developed countries, and really everything in between. You could be talking about smoke-free public housing, which was just announced in Boston yesterday by HUD. And so there's ongoing action, ongoing activities at all sorts of spatial scales and really around the world. And so it's a very interesting time to try to engage in these questions. And I think we have the right folks here in the room to try to answer them. And just to sort of reflect on this, I jotted down from the program the backgrounds of the people who will be speaking here today. And I need to look at the notes here because it's quite an impressive list. We have urban planners, social epidemiologists, environmental epidemiologists, community organizers, physicians, lawyers, environmental engineers, journalists, politicians, and a few others that I didn't have a chance to mention. And I think this is what you need if you want to address such a complex problem. We can't look at it from a single perspective. We need all these perspectives to come to bear. We integrate and we try to figure out what the answer is. So without further ado, I want to jump to our first keynote speaker who's going to launch our discussion about place and health. And this is Dr. Howard Frumkin. Dr. Frumkin is professor of environmental and occupational health and former dean at the University of Washington School of Public Health. His biography is, again, in your program, quite voluminous, too voluminous to mention. I do want to point out a couple of things. He's had many leadership roles in academia. He also spent time in government as the director of the National Center for Environmental Health and Agency for Toxic Substances and Disease Registry at the CDC. And he also serves on the board of many foundations and nonprofits. He also, as a few of us had been discussing yesterday, he literally wrote the book on a lot of the things we're going to be talking about here today. He's written many books. A couple titles that are key. He wrote a book called Urban Sprawl and Public Health, and he recently published a book called Making Healthy Places, Designing and Building for Health, Well-Being, and Sustainability. So I can really think of no one better to kick off this event than Dr. Howard Frumkin.
Good morning. John, thank you for that nice introduction. I've never been called too voluminous to mention before, but I'm working on that. A little physical activity and a better diet, and I should have it licked. I can't tell you what an honor it is to be here. So many old friends and highly respected experts in the audience. I do want to call out two people in particular. One is Sandro. Where is Sandro? There he is. This school has an incredible dean, one of the leading thinkers in public health in the country, one of the leading deans among schools of public health, catapulting this school to a tremendous position in the firmament of schools of public health. So, Sandro, congratulations. I also want to call out my friend Ron Sims, whom you'll meet later in the program. Ron and I flew out from Seattle yesterday, and we'll be flying back today. Ron is the closest thing we have in this country that I know of to a philosopher king. And I say that not just because we're both from King County, but because he is a deeply thoughtful and highly effective leader, one of the people I admire most, not only in our community, but in the country. So, Ron, great to be here with you wherever you are. Oh, way back there. Place and health. Let me figure out how to advance slides here. The importance of place for health dates back to ancient human history. So I want to begin back in historical time, and especially with Russ Lopez in the audience writing lots of history lately, this seems nothing but appropriate. The Old Testament, which was probably written 2,500 years ago or so, offers clear recognition of the possibility of unhealthy places, in this case, in indoor environments, in homes. There's a detailed description of mold infestation in buildings and specific instructions for remediation. I haven't given you the full quotation from Leviticus here, but interestingly, it describes the role of the priest in assessing and diagnosing the infestation of homes and then in guiding the remediation process, which I think is the earliest recorded evidence of an indoor air consultant. Hippocrates, the legendary Greek physician of the 5th century BC, entitled one of his works on airs, waters, and places, and wrote in it of the importance of the urban environment in determining population health. I've bolded in the passage that's excerpted here some of the factors he discussed, such as water quality and the siting of the city with regard to air movement and light. Clearly, place mattered for health back in Hippocrates' time. About 2 millennia later, coal burning in London had led to situations as intolerable as Shanghai and Beijing are today. Parliament petitioned King Edward I to ban the burning of coal in the city, and the king was sympathetic. It's said because his mother, Queen Eleanor, had been made sick by the fumes. He was a good son. The law imposed stiff fines and the destruction of furnaces in the artisanal shops where coal was being burned, and death for burning coal, making this the first example of a war on coal. It wasn't successful. Coal combustion continued in London for many centuries after this. Half a millennium later still, in the 18th and 19th centuries, the Great Acceleration began. This was the remarkable scaling up of human presence on Earth and of human activity enabled by plentiful, cheap energy in the form of fossil fuels. I don't know if you can read the names of each of the graphs from where you're sitting. Everything from GDP to foreign investment to population. But the 2 items that I've circled here are urban population, the concentration of humanity into larger and larger cities, and the widespread penetration of motor vehicles indicated by the transportation graph there were 2 of the features of the Great Acceleration that marked the move into modern times. The rapid growth of cities during the Great Acceleration gave us infamous tenements, such as the one shown here, marked by crowding, poverty, inadequate infrastructure, and the spread of infectious diseases such as tuberculosis. Following the widespread penetration of cars in the 1920s, and especially following the Second World War, a vast migration from cities to suburbs began. Push factors drove people out of cities, and pull factors pulled people toward the suburbs. These factors included zoning and mortgage policies, racism, the desire for more room, and the appeal of green space. In both the urban and suburban context, it was clear that where you lived could affect your health in many ways. In 1948, the American Public Health Association issued its Planning the Neighborhood Standards, which primarily focused on the context of housing. The main goals remain close to the mark today, with reference to injury prevention, infection control, lighting, clean air, noise control, and even aesthetic satisfaction. There's also reference to protection against moral hazards, and we can only guess what they had in mind back in 1948 when they talked about that. As Sandro mentioned, in the last few decades, we've seen a remarkable upsurge in activities related to urban health, as indicated by this graph of books published on the subject from the Open Library Internet Archive. A huge upsurge. Some of these books are shown here. Some of the authors and editors are sitting in the audience today, together with the logo of a professional society reflecting the upsurge of activity around urban health in recent years. This attention has expanded to the scale of buildings as well, as indicated by the books shown here in a couple of sample logos, one from the American Institute of Architects, which has an active design and health initiative, the other from the International Well Building Institute, a private sector effort. All this work, from the metropolitan scale to the building scale, comes with certain perspectives grounded in particular disciplines and ideologies. Let's consider several of the lenses through which people have looked at how where we live can affect our health and review the insights they've yielded. I'll then conclude by calling for a broad vision that blends all of these lenses. The first lens is the field of environmental health, the field that focuses on physical exposures and circumstances. Here's a typical environmental health framework from a just published paper called City Planning and Population Health. You can't read the words within those boxes, but don't worry. You'll notice that the blue line across the bottom, corresponding to socioeconomic position and area level disadvantage, operates across the framework. But other than that, almost all of the boxes in this framework relate to physical factors: land use, transportation infrastructure, housing, air pollution, and so on. A fairly typical format for environmental health thinking. Analyses in environmental health have taught us a great deal. For instance, urban density, grid-like street networks, connectivity, an admixture of commercial, residential, recreational, and other land uses, pedestrian and bike infrastructure, and attractive human-scaled streetscapes depicted on the right side of this cartoon, in contrast with the opposite features depicted on the left, are associated with less motor vehicle use, greater physical activity, more social capital, and the many health benefits that flow from those things. Poorly planned infrastructure, on the other hand, can not only discourage active travel, but actually make a mockery of it. Transit infrastructure not only moves people efficiently, transit users on average get substantial amounts of physical activity from walking to and from the transit nodes. That has important public health benefits. An urban form has an impact on motor vehicle injuries and fatalities, the leading cause of death among young people in this country. This map shows that the older, denser cities in the country, those with more pedestrian and transit infrastructure, have substantially lower motor vehicle fatality rates than the more recently developed automobile-dependent sprawling cities. Phoenix has a motor vehicle fatality rate 3 times higher than New York's, and the difference between those two is what we call in the trade preventable deaths. We also know that contact with nature and green space offers a range of health benefits. Since our population overwhelmingly lives in metro areas, much of nature contact occurs in parks and green space in cities, which become promising venues for health promotion. Importantly, access to parks is not equitably distributed across the population. In some cities, research shows that poor people and people of color have less access to nearby parks. In other cities, this disparity doesn't show up, but almost invariably there are disparities in the quality of parks, in their maintenance, and in the facilities and programmings that the parks offer. This contributes to place-based health disparities. The range of benefits from nature contact boggles the mind. Evidence shows that people in greener neighborhoods or people who live near parks and green space enjoy better birth outcomes, lower levels of obesity, lower levels of stress, better general health, lower mortality rates, and much more. Noise is a nearly ubiquitous feature of urban life. As shown in the diagram on the left, ambient traffic noise reaches about 70 decibels, motorcycles 90, subways 100. The cartoon on the right is a reminder that even within buildings there are many sources of noise. Noise has a number of adverse effects on health and on well-being. This is an environmental exposure that deserves more attention than we typically give it. Another important environmental exposure is temperature and humidity. As shown in this diagram, there is a comfort sweet spot, roughly between 72 and 80 degrees Fahrenheit and between 40 and 60% relative humidity, at which most of us feel best and function best. Buildings ought to aim for that range. But heat isn't just a challenge for indoor environments. Cities are warmer than the surrounding countryside, a phenomenon known as the urban heat island effect, due to the dark heat-absorbing surfaces in cities, the loss of evapotranspiration from what would otherwise be trees, and local heat generation. And the heat island effect isn't consistent across a city. This figure shows heat distribution across Boston on a summer day, and it reveals a range of well over 10 degrees. Here, too, we see disparities by social position. This study of Phoenix documented the existence of microclimates across the city during the 2003 heat wave. During that heat wave, historic Anglo-Phoenix, a relatively well-off white neighborhood, was 13.5 degrees Fahrenheit cooler than Black Canyon Freeway, a poor, mostly Latino neighborhood. The investigators in this study attributed the difference to the lack of vegetation and open space in Black Canyon Freeway and the proximity of large expanses of asphalt, which gave Black Canyon Freeway its name. Moreover, poorer families are less likely to have the major protective device, air conditioning. And of course, chemical exposures where you live can be bad for your health. Lead paint was used for decades in American homes and commercial buildings, and it remains in place in many older buildings, where poor people and people of color are disproportionately exposed. The health consequences, especially for children, can be severe. Other toxic exposures in buildings include asbestos, pesticides, and volatile organic compounds. Environmental health research has documented the patterns of exposure and the adverse health effects of many such hazards. But there's an entirely different lens through which urban health can be viewed, the lens of social determinants of health. This perspective is represented in the diagram, which everybody in the room has seen, the notion that people are embedded in a context that is socioeconomic, cultural, and political, as well as physical. As the field of urban health grew over the last half century, and as many inner cities became the sites of concentrated poverty and deprivation, the social determinants of health perspective became central to our field. The graph on the right shows the suburbanization of one city, Philadelphia, over more than a century. The city itself, is shown in yellow, peaked in population in the decade after the Second World War and declined thereafter. Meanwhile, the inner ring suburbs, shown in green, expanded dramatically, and the outer ring suburbs, shown in orange, followed. The shrinking urban tax base, the loss of economic opportunity and services, the grinding effects of racism and poverty took a terrible toll on urban health. Urban unrest peaked in the 1960s, both resulting from and contributing to racism, which further entrenched segregated residential patterns and intensified the concentration of poverty in cities. Now, poverty, deprivation, discrimination, and inequality are bad for health. We have extensive epidemiologic data to make this case, no surprise to anybody in this room. We also have extensive data from our cousins, primates, such as these macaques, that help clarify some of the mechanisms of action. Social determinants alter everything from gene regulation to epigenetic changes to outcomes such as atherosclerosis and infections. The social determinants of health have a firm scientific foundation. And to the extent that social determinants are place-based, anchored in geography, then urban health is very much grounded in these factors. Here are some maps of my home county, King County, Washington. This is a county with exceptionally good average county-wide health indicators. But disaggregate us by census tracts, and you see the pattern shown here with blue being healthier and red less healthy. The southern part of the county is the most diverse, the poorest, and the reddest on every health risk and disease outcome depicted. Interestingly, the social determinants of health perspective has dominated urban health in recent years. I took a look at a random selection of 8 issues of the flagship Journal of Urban Health for the period 1998 to 2013. The issues I picked had a total of 109 papers. I assigned a topic to each paper, or when appropriate, several topics to a paper, and the topics are shown here. You'll see that substance abuse, HIV/AIDS, healthcare delivery, poverty, and sexual health issues dominated the publications, eclipsing the environmental health topics such as neighborhood design and housing I discussed earlier. Of course, both perspectives, the environmental health perspective and the social determinants of health perspective, are right on target, and we need both. There's good work that combines both perspectives, and we need more of that work. But we need to go farther if we're really to understand how where you live can affect your health. A third lens comes from the increasing recognition of the nexus between cities and climate change, as exemplified by the books and organizational logo shown here, and the op-ed in yesterday's Times, whose headline I've put on the slide. Climate change, of course, is a looming public health challenge. The urban connection is a matter of mitigation. Cities are the source of as much as 70% of greenhouse gas emissions globally. Cities are also economic engines that embody many decisions about energy policy, transportation policy, and buildings, arenas that are central to the transition to a post-carbon economy. But the role of cities is also a matter of adaptation. with the majority of people globally now living in cities, and in countries such as the US, a very large majority, protecting people from the effects of climate change is very much a matter of protecting cities. However, much of the literature, the books shown here and much of the papers that you can read, focus on design and infrastructure issues and make only passing reference to public health. Following the election this month, it's clear that cities will fully replace the federal government as the locus of practical science-based progress in mitigating climate change, at least in our country. Cities are promising venues for climate change mitigation, although the per capita carbon footprint of urban dwellers is substantially lower than that of rural dwellers. The aggregate number of people in cities means high aggregate carbon emissions, and the spatial arrangement of cities makes climate-friendly policies feasible. For example, cities can embrace mass transit and infrastructure for walking and cycling, mentioned earlier, but in this context, very relevant to climate change mitigation, reducing one of the largest sources of carbon emissions. Similarly, cities can implement building codes that require energy efficiency, a high-impact move since many cities are seeing high levels of building these days. Cities also offer critical opportunities for climate adaptation. For example, urban heat waves can have serious public health impacts. A wide range of adaptation strategies, from planting shade trees to heat wave preparedness planning, can help protect the public. A fourth and related lens is the concept of resilient cities, a recognition that many cities are vulnerable to disasters, ranging from coastal flooding to heat waves, from power outages to earthquakes. The books and organizational logos shown here exemplify the concerns with urban disaster preparedness and response as part of resiliency. This literature, too, has a strong focus on infrastructure, but also on soft assets, such as social connectedness within communities, issues that are highly relevant to public health. In the event of a disaster, whether or not you live in a neighborhood where you know your neighbors, where you and your neighbors help each other, has a great deal to do with your health. One example is urban flooding, a phenomenon expected to occur more commonly as climate change progresses. The picture on the left is New Orleans after Katrina. The picture on the right is Bangkok during the 2011 monsoon season. Floods are a salient example because so many of the world's cities are located along rivers or coastlines and are subject to flooding. Various authors have forecast which cities face the highest risk of flooding now and in the future. Two projections are shown here. There are a lot of cities shown. Which city you live in and which neighborhood within that city greatly affect your risk. Climate change mitigation will reduce this risk globally, and adaptation will reduce the risk locally. The same is true for other disasters, such as earthquakes. As this figure shows, the highest numbers of people at risk of earthquakes are those concentrated in cities in seismic zones. Many of the attributes that build resilience against flooding are just as relevant for other disasters, such as earthquakes. These attributes are shown here in a graphic from the 100 Resilient Cities Network. Of note, some of these attributes, inclusive decision-making, integrated systems within the city, flexible and adaptive strategies, are part of the public health canon. In fact, this model of urban resilience, again from 100 Resilient Cities, includes health and well-being as well as leadership and strategy, infrastructure and environment, and economy and society. This could well be a framework for action for any city's health department. Importantly, it would guide the health department to collaborate closely with the housing department, the water department, the transportation department, the parks department, the school system, the private sector, civil society, and others. More about this multi-sectoral collaboration in a moment. A fifth and also related lens is the growing focus on sustainability in cities. Sustainability encompasses concerns with climate change and with resiliency, but it goes farther, focusing on urban metabolism, the flows of goods, services, and energy, the ecological footprint of cities, and the ways in which ecosystem services are used and valued. This set of concerns, exemplified by the books and organizational logos shown here, also includes a strong emphasis on social equity within cities, resonating with the social determinants of health lens I discussed earlier. Health itself is often mentioned in the sustainability literature, but unfortunately, often in passing. Sustainable cities have attributes that overlap considerably with those of healthy cities, climate-ready cities, and resilient cities. Many cities have developed sustainability plans and identified metrics, and they track those metrics using dashboards like the one shown here. You can't read the small print, but across the top, the elements good governance, energy, mobility, water, ecology, waste, and community health are typically tracked. Other elements such as equity, economic performance, education are also sometimes included. Even if there are few explicit health indicators, these dashboards include many elements of sustainability that are directly relevant to health. Cities consist, of course, not only of streets and neighborhoods, but of buildings. And the green building movement, a close relative of the sustainability movement, has seen extraordinary growth over recent years, exemplified by the books and organizational logos shown here. Again, while health is often mentioned, it's rarely a central focus. But many aspects of green buildings, natural daylighting, irresistible staircases, the reduction of toxic chemicals in the buildings are clearly good for health. The final lens I'll mention is the lens of urban ecology, the interest in cities as parts of complex ecosystems evaluated in terms of hydrology, plant ecology, and related disciplines. This lens is to date the least integrated with human health. But in the long run, living harmoniously with functioning ecosystems is a prerequisite to sustainable human health, a clear instance of how where you live can affect your health. You won't be surprised by my conclusion that all of these lenses ought to be combined, just as this critter combines lots of lenses in one pair of big googly eyes. In order to understand fully how where you live can affect your health, and just as important, in order to envision and work toward places that promote health and well-being for all, we need to fuse the perspectives of environmental health, social determinants of health, climate change, resilience, sustainability, and ecology, an effort exemplified by the books and the organizational logo shown here. Just a few closing thoughts about what this means in practice. First, we need to think in systems and do what might be called full benefit accounting with regard to the places we make. Shifting travel from single occupancy vehicles not only reduces the carbon footprint of the transportation sector, it also promotes physical activity, improves urban air quality, and reduces deaths from car crashes. Promoting urban and peri-urban agriculture not only reduces the carbon footprint of the food sector, it also results in healthier diets, reducing the risk of cardiovascular disease and cancer. Urban tree canopy not only reduces the urban heat island effect, it also helps with stormwater management, provides shade, improves air quality, and offers a range of health benefits. Such win-win, no-regrets solutions have to be at the center of envisioning and creating great places for people. We also have to do full cost accounting, avoiding the presumption that something that seems good in one way is good in lots of other ways automatically. A key example is gentrification, urban development that drives up real estate prices and displaces communities. Here, good placemaking collides with social equity, two worthwhile goals that don't go along with each other. A subset, green gentrification, was recently described. Improving parks and green space, driving up nearby home values, and leading to displacement. I'm told that some savvy, lower-income communities have actually resisted green space and parks, knowing that the greener community they would otherwise prefer could price them out of their homes. The market will never solve this problem. Effective social policy is needed. Another example of colliding ideals is the move toward building microhousing in cities, entire apartment units that can be smaller than 300 square feet. In cities with dramatically rising housing prices, where inventory lags well behind demand, these units represent one strategy for providing more affordable housing. But they're often prohibited by housing codes from a century ago, when crowded tenements, like the one shown here, were hotbeds of infection. How do we resolve this conflict in ways that optimize health and equity? Well, the growing public health focus on place, on the built environment, has taught many of us to channel the design and planning professions, to think in systems, to think geographically, and to think upstream. Whether you call this upstream public health or public health 3.0 or lateral public health, it's a highly useful approach not only in addressing urban health, but also in addressing broader issues of global change, sustainability, and planetary health. Cities and within them buildings are increasingly the prototypical human habitat. Where you live can affect your health, and place-based public health offers enormous opportunities for the transition to a healthy post-carbon economy, for demonstrating the co-benefits that result, for advancing social justice, and for communicating these benefits to the public and to policymakers. Thank you very much for your attention, and I look forward to our discussion. John, questions? Or?
Yeah, it's time for Q&A.
We're open for comments and questions. There's a hand back there. Yes, ma'am.
I like the fact that you broaden the lens to look at certainly public health, but there's, I think, one segregation of not only where do you live, but what do you do. Occupational health is certainly segregated out from environmental health and should be integrated, certainly in this viewpoint.
I couldn't agree more. It's place-based health includes the workplace. And I didn't mention it. Thank you for bringing that up. But many of the same principles that govern health in workplaces extend and teach us lessons about health in many other indoor environments. Jack.
You mentioned the importance of cities.
Got a microphone coming.
You mentioned the importance of cities now. And in the context of what you presented, give us some inspirational cities. Who's doing it right? And where are they? And what are they doing?
Thanks. The question was inspirational cities that are doing it right, and I think there are good examples, interestingly, not only from the north, but from the global south as well. So a shift toward non-motorized transit in cities like Curitiba, Brazil, and Bogota, Colombia. A shift toward green spaces in many of those same cities. Here in this country, we're seeing better pedestrian and bike infrastructure. We're seeing better building codes. We're seeing an emphasis on parks and green space. Not only in the cities of the NPR archipelago, where you would expect them, from San Francisco to Seattle to Burlington to Boston, but also in unexpected places, Salt Lake City, cities of the Texan tier, where sensible, transpartisan, people-based planning is really moving ahead. So there are lots and lots of cities where we can take inspiration. These days, it may be hard to feel optimistic about things in general, but I think looking at what cities are doing is a great source of optimism. Yes? There's a microphone coming your way.
Good morning. Thank you so much for your presentation. My name is Jessica. I work for a city councilor here in Boston, Ayanna Presley, and we're working on this idea about zoning for healthy communities. And one thing you commented on the end has come up in some of our conversations with community members saying, well, we don't want to talk about what will make our community healthy unless you're going to tell us how we're going to be able to stay in our neighborhoods. Because once you bring these improvements, we're going to get priced out. And so I'm really interested as someone who works for a policymaker is thinking about how we involve community in these discussions. I think a lot of your visuals indicate that tension that happens between governing and community. And so I'd be curious your thoughts about how you do that in Washington. And one recent idea we were just brainstorming, a group of us on this project that we have, is including more public health researchers and experts on our impact advisory groups that are informing how development is happening in Boston. So I'd love your thoughts on that as well. And anyone who wants to be involved, let me know.
Thanks for the comment and question, and thanks for being here. It's just wonderful when city council staff come to an event at a school of public health. This completely vindicates Dean Galea's strategy of turning the school inside out. Okay. You trained them well. So two comments to make. I was just talking with Carlos Doro, whom you'll hear later on today, about this huge challenge of maintaining housing, what's called social housing in Europe, affordable housing, in the face of rising real estate values and redevelopment in cities. It has to be a matter of social policy. And typically the strategy is something like, when a developer is putting in housing, you get from the developer either a pledge to build affordable housing alongside the market rate housing, or to provide funds to the city government, which then does that. Then the trick becomes keeping the housing affordable through the turnover of the housing over time and through the changes in the marketplace. And it's a really difficult social policy challenge. It's, I think we'll have a chance to hear about how that happens in Europe as well, and we get some good lessons for the States. We don't consider housing to be a human right here perversely, as some other countries do, but it is. And the way we can build the social policy to assure sustainably affordable housing is really important. Second thing I want to mention, and this relates to my hometown, to Seattle, is that when public housing is built, public health can be very deeply involved in that. We've got a terrific example, a place called Yesler Terrace, which is one of the early public housing projects in the country, in Seattle, where asthma-free housing was built as part of recent redevelopment there. And it was based on research that was place-based research that was done there, so we know something about what it takes to make housing asthma-free, and built accordingly. It was a nice partnership between the public health department, public health researchers, and those who were in charge of putting the housing together. So weaving that health and well-being thinking and evidence-based design principles into the construction of public housing is a practical thing to do, and really it works. Very gratifying to do. The first thing we have to do is get more public health graduates working for city council staff members. And yes, sir, in the back and then up here. Yeah.
Good morning. Thanks so much for the talk, and excuse the horsey voice. But I just wanted to offer one other potential lens, maybe, and that is social capital, based on your comment. Thanks.
Social capital is an extraordinarily powerful predictor of good health, and it's the glue that holds communities together. And we don't usually think of it in the environmental health context as much as we should, but in the social determinants of health frame, it's an extremely important factor. So thanks for calling it out. I think the gentleman right in front of you had a hand up too, or was I mistaking your hand for that hand? Nope, okay, up here.
Yeah, just another question. You know, starting to see some instances where we have hospitals and healthcare systems making investments in housing and healthy neighborhoods beyond just community benefits, but on the investment side. So as we try to think about housing policy folks thinking about health, this is really leveraging a whole, you know, your anchor institution kind of framework, but also assets. So just comment on where you've been seeing that trend going. I can think of, say, 8 terrific examples, but I don't know, perspective on that.
Yeah, thanks for the question. Good question. And I don't know much about it. I know of a couple of examples in our area in Seattle where a clinic what began as a clinic network for underserved populations called CMAR has expanded its self-definition and now offers affordable housing, elderly housing, and job training in complexes that surround some of its clinics. So it's really it's a break down the silos, think holistically about what the population you serve needs approach, and it's a great thing. There are efficiencies, obviously, that can be realized when you do that. A friend of mine who is the public housing director in Boulder firmly believes that public housing isn't just public housing. It's a venue for making people's lives better. So they've got childcare, they've got educational programs and job training programs that are embedded in the public housing there, and it's also a very good model. So all of this leads to the same general conclusion, and I want to shout this out especially to the students in the room. You may think that what you're working on is public health, but think as broadly as you can about the components of good lives, about what people need across sectors, and think about the most comprehensive way of delivering those things. Carlos.
How many of those books speak about the role and the contribution of the health sector specifically? Because the knowledge we're producing, but how much in terms of the translation into, is there any, how much thinking have you seen on that direction?
So how many of those books actually relate to the contributions of the health sector? It varies with the field, but I'd say disappointingly few across the board. In fact, it's interesting if you pick up a typical book on urban sustainability and look for health in the index, you may not even find it. So in many cases, The perspectives of the authors are the ones that dominate. The sustainability field really comes out of a physical science and engineering framework, and it's migrated toward health, but often we haven't done our job well enough by forming those alliances so that sustainability thinking or green building thinking or resiliency thinking weave into them the health components. And you asked about the health system in particular, the healthcare delivery system, and that's even further behind. I mean, there's public health, which is a small piece of the health sector, and then there's the healthcare delivery system that is often not at the table at all, but ought to be. Yes.
Thank you for this. It seemed to me that one of the lenses that you might have added that affects most of what you talked about is tax policy, because tax policy drove a major portion of the exodus from the cities. You mentioned that, but didn't, I think, focus enough on how important a driver that really is for everything that you were talking about.
Thanks. Very good point. And I would even expand that. I'd build on your point to talk about mortgage policy and zoning, redlining. There's a whole series of social policies and financial policies that shape the way we live, which in turn shapes health and well-being. So I wasn't as comprehensive as I could have been. Thanks for the comment. Other questions or comments? Well, thank you very much for your attention, and I hope that we have a great day together.